Thank you so very much. It's really a pleasure to join this extraordinary faculty and begin by congratulating Professor Yacoub in really designing not only one of the most cogent topics in world health today, but really attacking this at a fundamental level away from pharmacologic therapy. Most of you saw the recent attention that the Novartis drug has received because it was the first drug in 15 years that we've seen any improvement. And so pharmacologic therapy is not, we've certainly got a cornerstone of being able to advance, and when we follow the guidelines, it has a lot of impact. But I think that the world is going to see a very different non-pharmacologic approach, and I, again, congratulate. I also want to congratulate Dr. McKenna on a personal level, but I think it really sends a very big signal about the quest to not just achieve excellence here, but to really become a player in the world stage. And I think as we learn these 2,000 ACS and 800 acute PCI cases, I think that this is going to be a leading center, and I really look forward to the progress that's so apparent. Well, Dr. Bono has really set the stage for the global impact of heart failure today, and as we see these epidemics of atherosclerosis in China and India and highly populated areas and see the progression to heart failure, this is clearly going to become one of the most dominant health problems in the next several decades. And I think this graph really calls to attention. In the United States, over 2/3 of all that expenditure of over $30 billion for heart failure care is inpatient care. And I think this graph really makes the statement that as we get to this crest of where people begin to be hospitalized, that's the greatest change in their prognosis and obviously the greatest impact on the healthcare economy. And so it really draws a lot of attention to how do we identify these people who are becoming worse and try to avoid those hospitalizations. This is data that I think is shared in the world, really. This came from Canada, and it's certainly been populated in the United States, that are very staggering, because once we have patients hospitalized for heart failure, you'd think we would really have them under our care and we would bring advanced therapies to them, but it's very impressive that no matter what we do, over 20% of people are readmitted within 1 month and 50% of people are back within 6 months. And I think that's a staggering statistic about what we're able to intervene once people get to that level of advanced heart failure. But I think it's also sobering when you see whether they have preserved or reduced systolic function, that 1/3 of those patients will die within a year. And so again, it emphasizes our risk assessment in all the patients we follow to try and prevent this very morbid disease. There have been probably at least 40 major risk factors identified over the course of time, largely by univariate analysis, that have shown a correlation with the progression in heart failure. We're focusing now on hospitalization for heart failure as well as mortality, but I think these are very difficult in a practicing level to keep track of all the different variables that have been advanced. I want to begin by talking about the difference between preserved and reduced systolic function. This is an interesting look at the spectrum of the ejection fraction in people followed in a heart failure clinic, and I think you can see that there, whether it's men or women, there still is quite a spectrum of people that have relatively preserved systolic function. We have very little data focusing just on that population, so I'm going to extrapolate this data, although we have data from Mayo Clinic that has shown that the mortality in today's world, whether you have reduced or preserved systolic function, is the same. And so we'll assume that while there are certainly different comorbidities in the people with preserved systolic function, I think identifying them with BNP and other variables will be quite helpful. Well, one of the factors that we always point to when we talk about a patient is what is the ejection fraction, and I think that it would be nice if that really had a lot of substance, but I think as you can see that you'd rather have an ejection fraction of 50% than 30%, but when you get down into the more reduced levels, it doesn't have as much risk stratification, and when you follow patients for a long period of time, you may see people with an ejection fraction of 20% who stay at that level for the next 5 to 10 years and function rather surprisingly. But you'll see people with a 25% ejection fraction, where they have significant mitral regurgitation or other comorbidities that may make their prognosis quite a bit worse. One of the factors that we don't do as much at an academic center and certainly in other facilities is look at one of the variables that has had the greatest duration in terms of being one of the leading prognostic indicators, and that is functional performance in terms of peak oxygen consumption. Based on a treadmill and measuring oxygen consumption, this is data from Donna Mancini now nearly 20 years ago, that identified 100 patients who all came in for a heart transplant evaluation and did peak oxygen consumption, abbreviated here as VO2. And I think you can see they all seem the same, they all had similar limitations, but when you see those that were preserved in their peak VO2, they had really quite a good prognosis, and this went out over several years. Those that had a somewhat reduced their survival or need for transplantation mechanical support was quite a bit worse, but those that had this really significant decline in peak VO2 had a very bad prognosis. And this has really stood the test of time, because when you look at this by multivariate analysis, the peak VO2 has stood the test as the most highly correlated with prognosis in comparison to several parameters of hemodynamics, etiology, and other demographic features. But as I mentioned early on, this issue of hospitalization, I think this is a very important slide that Lynn Stevenson and the group in Boston have really shared with us, that in the United States, we see a lot of people come in and they stay for 2 days and they start looking a little better. We send them home and then they come back again. I'm not sure how prevalent that is here, but I think we forget that every time someone comes in the hospital, their survival goes down. And this is really, again, that curve I showed in the very beginning, that once they get into that realm of repeated hospitalizations, their prognosis is bad. And we really talk about assessing that patient who comes in, particularly if they're already on medical therapy. That hospitalization, if it's the index hospitalization, is a critical time to ask, are they candidates for more advanced therapies? What else can we do at that time rather than letting this progression of disease and repeated hospitalizations go forward? Sorry for this looking rather complex slide, but it was an important slide and data we did from a study published in the year 2000 that looked at patients who were randomized to a mechanical support device or medical therapy. And we did a fairly extensive multivariate analysis, and one of the observations that we showed then that has also stood the test of time is that if for cardiorenal symptoms you were unable to take adequate doses of an ACE inhibitor or a beta blocker, it had a 10-fold increased risk of mortality in the ensuing year. So when you see people whose creatinine is already elevated, they're not able to take that, blood pressure is a limitation, and those factors limit the ability to give what is considered primary therapy. I think that has one of the factors that we really diminish. You say, well, my patients are on guidelines, but they're taking such inconsequential doses of those medications. All of the benefit that we see are in the trials in which those guideline-based doses were used. So being unable to tolerate those doses is a significant impact. This is data from Lynn Stevenson, again looking at if you were unable to take that because of cardiorenal limitations. If you were just on a low-dose ACE inhibitor, this was the prognosis, but if you got into worsening heart failure, it really reflects that the prognosis can be quite substantial, especially if they require intravenous inotropes. One of the laboratory data that we know most about from many years ago, Milton Packard first to make this observation, that serum sodium as a marker of persistence of stimulation of the renin-angiotensin system, again, particularly if you're on an ACE inhibitor, really is a profound manifestation of advanced heart failure. If you cannot maintain a sodium above 136, the prognosis is really quite reduced, and it's a continuous variable in that the lower that sodium is, the more it represents a significant ongoing risk factor. So that's a laboratory variable that in the most recent analysis has stood probably one of the most important laboratory manifestations. But one of the variables I want to talk to you about today is renal function, and I think we've really begun to focus on the importance of renal dysfunction. This is from a European study in which they just looked at and measured creatinine clearance and then followed these patients over a period of time. And this is really relatively modest reduction, and you can see the reduction over the next 2 or 3 years in survival, but each 10 cc reduction in glomerular filtration rate has a really profound, and this is not considered terribly abnormal, but look at the difference in outcome down at 40% survival in 3 years in those people who have a GFR of less than 45 cc's. And I think this data is supported in a number of other variables. I hope that you've seen this rather extensive database that was accumulated in the United States called ADHERE, and it's really been one of the fundamental foundations we look back in understanding outcomes. And when we looked at mortality in the ADHERE database, and this was designed to be a database in 5,000 people, and in the first 2.5 years we had 150,000 people, and it was just a registry describing how they were managed, where they were cared for, and so forth. And we saw that the mortality ranged from 1% to 20%. And so we focused on that 20% mortality group and tried to understand what were the variables. And after an extensive look, those patients who were admitted with a BU1 over 43, a systolic blood pressure less than 115, or creatinine over 2.7, had a 22% mortality in the hospital. And this has been reproducibly shown, the so-called cardiorenal syndrome. They are in the hospital longer, cost a lot more, and have a much worse prognosis. That is a concomitant covariate in patients with heart failure, is probably one of the worst prognostic variables. And I show you this data from the first slide that showed you the impact of subsequent hospitalizations. Look at the mortality if you have combined chronic renal insufficiency with the heart failure population. It has a profound impact. And again, that index hospitalization, those patients in this category are really worth an intensive look for other alternative therapies. And finally, I'll show you some more data from the CL heart failure database of 10,000 patients, but one of the surrogates of renal dysfunction is the dose of diuretic that's required, and we're not quite used to thinking about it in terms of milligrams of Lasix equivalent per kilogram of body weight, but a very, very impressive stratification of lower doses versus when you get up as high as 4 milligrams per kilogram, and you can see the extraordinary impact that has on mortality, all reflecting renal dysfunction as a bad prognostic factor in patients with heart failure. Well, of all the laboratory tests that have been out there that has really gained clear acceptance and verification, it is brain natriuretic peptide. This now has gone to about 4 different iterations in terms of the amino acid number and the assay. But I think it has been looked at. This is from an emergency room looking at the BNP level at the time of being seen, and then looking at prognostic, and you can see the death or heart failure hospitalization in those with an elevated level, and this is about 4 times normal, is really quite profound. This is data that's just been reviewed by Javed Butler in an upcoming article that looked at pre-discharge BNP, and again, it's a little bit different what the particular cut point is that you've looked at, but I think it makes a very strong argument that BNP is really able to identify those patients at risk for progression. One of the areas that we also don't have a lot of data on that is relatively common looking from the Framingham heart study are those patients that we find looking at cardiac evaluation for surgical procedures or other incidental observations that show us an asymptomatic patient with measured LV dysfunction. And I think it's not such a benign prognosis. I think you can see if you look at ejection fraction as it begins to fall below 40%, these people have quite a reduced outcome even though they're asymptomatic in comparison to those with reduced systolic function. And there's been some recent review again that the risk of death and the risk of heart failure can be stratified by what their BNP levels are even in the asymptomatic population. So whether it's asymptomatic or preserved systolic function or reduced systolic function, the BNP level has been quite impressive. And the last of the biochemical variables is hematocrit. Not a very commonly thought of variable, but I think it has significant impact. This is from a large cohort with Greg Fonerow in Los Angeles, and again, this would be normal hemoglobin, and an interesting observation of the impact on urgent transplant. But look at a hemoglobin less than 11.8. Look at how the stratification. So we see these variables that really allow us to really break them out and look at quartiles of risk, and I think hematocrit is now, at least in the oral supplementation, didn't have much benefit, but the recent trial with intravenous iron seem to have quite a beneficial effect, and again a target for how we might be able to help these people. And the last of these variables that I want to focus on is another one that we really don't spend a lot of time on. There are several trials suggesting as much as 30% of the heart failure population have measured defined malnutrition. And if you look at the basic metabolic index of these patients at a particular cut point, and again, most of these variables are continuous variables, meaning that it's not just above or below risk or not, but I think you get a sense of what the one-year survival differences are in those patients who have malnutrition. And I think there are a number of biochemical assays that are easy to obtain that really help stratify. Just crude albumin is a very crude marker, but prealbumin and transferrin are two things to really get a sense of that, and focusing on nutritional supplementation may be quite beneficial in those with most advanced heart failure. Other variables that have been known for a long period of time, and if you look at just left ventricular end diastolic dimension, just on chest x-ray, I think you can see the difference in survival when the heart begins to enlarge and remodel. This is a very interesting observation of the difference of it only takes a little bit of improvement in reducing LV remodeling to see a significant reduction in mortality. So this is becoming one of the endpoints in stem cell trials, is reducing LV end systolic volume. Well, I've given you a look that there are a number of individual variables, but keeping track of all of them is somewhat of a challenge. And again, they're univariate analyses, and so when you begin to put the variables together, this is one of the first ones that was developed by Donna Mancini and Keith Aronson in the early 90s, and has subsequently been revised after that with the advent of intense beta blocker therapy. And I think you can see that the variables that were used early on, they were some of the first to look at wide QRS, peak VO2, ischemic etiology, and so forth, and you get a point for each of these that are present and abnormal, and I think you get a very clear stair-step impression that low, medium, and high risk is very associated with prognosis, again, almost identical even in the beta blocker era. But the score that probably has gotten most adoption in the heart failure community is that from Wayne Levy, the so-called Seattle Heart Failure Score. It was derived from a population of 10,000 patients in the PRAISE study, an outpatient oral heart failure study. And so this model has been manipulated that you can put up on your computer, and we use it often in the clinic to look at the relative risk, and that you could also see the potential impact of interventions like ICDs and pacemakers and so forth. But I think this is the kind of data that we're always looking for, to look at the individual patient and try and say, where would you fall on that? And it's very interesting, then they did this extensive multivariate analysis. And interesting, as we mentioned earlier, diuretic dose turned out to be the most correlated with prognosis, a lower blood pressure. And I think when you look at total lymphocyte count, that probably is on many people's radar of how to follow these people. And if you think of total cholesterol, it must be the ischemic population and a high cholesterol. But actually, these are very good markers of malnutrition, and particularly cholesterols of as low as 100 or below that, and total lymphocyte count reflecting malnutrition. And this is a very important part of the prognosticator. But again, we end up with, a smaller group of people that are in this higher risk category, but it has certainly been one of the areas that we focused on. Unfortunately, when you look at this list of variables that were included, renal function didn't fall out, despite that being such an intensely important, nor does it include hospitalization. So it is a little bit dated already, although has been one of the important ones. And finally, I'll focus on, once we get people in the hospital and you think, are they candidates for advanced therapy? Is it too soon or too late? And how do we stratify those patients? We worked on a large cohort of patients that were awaiting a left ventricular assist device, and found these 9 variables were the highest correlated with mortality with getting a mechanical assist device. And we looked at them in the weighted risk and hazard ratio, and then awarded points based on that, and got a cumulative score. This is a surgical intervention, and it was interesting that we had very modest appreciation of how important malnutrition was. And I think the importance of this data is that it gave us a low, average, high, and very high. So preoperatively, you can identify the patients that have the highest risk of not surviving the operation. When we looked over time, these variables stood up, and we again tried to identify those patients who had as low as an 8% likelihood of surviving 1 year, and I think we can exclude those patients. So we can look at risk stratification when they're in in between phases and even when they're in their most advanced phases in terms of risk for surgical intervention. So I'll end with really recapping those variables that I think are very important to keep in mind as you're following patients, and I think the one that I focus on is heart failure hospitalization, particularly if they're already on relatively optimized medical therapy. BNP is really becoming one of the more important laboratory variables, and again, greater than 4%. It's a continuous variable following them. Renal dysfunction is a persisting key. Low sodium, high diuretic, the inability to take an ACE inhibitor, ARB, or beta blocker because of physiologic limitations, and a large ventricle evidence of remodeling, and reduced peak oxygen consumption and functional capacity. So I think in summary, I'd say there are multiple factors that are out there, but I think we're looking at new composite risk scores. There's an NIH initiative called METAMAX, and we're really looking at people with advanced failure, folding in the variables of renal dysfunction and hospitalization, some of the things that weren't in the previous risk factors I described. But I think the future is really going to point us in this direction. How do we follow people? How do we identify those who are at risk for progression? Thank you.